main parameters that are covered in the history taking. So we have family history, mainly consanguinity and history of neonatal cholestasis in the parents or siblings, which are related to all these autosomal recessive disorders, cystic fibrosis, alpha-1 antitrypsin, PFIC, and Alagille syndrome can also be inherited. If there is a history of repeated fetal loss or early demise, you have to consider gestational alloimmune liver disease. So this is like alloimmune hematological conditions, but here the alloimmunity is to the liver material itself. The main feature here is a very high risk of coagulopathy in the newborn. They often lead to death. Spherocytosis and other hemolytic diseases, I mentioned the risk of biliary sludging, and they can aggravate conjugated hyperbilirubinemia through that. And you look at the prenatal history, the prenatal ultrasound findings may sometimes pick up choledochal cyst. And if there are bowel anomalies or there are syndromes, you may pick them up. And cholestasis of pregnancy can often be seen in carriers of the PFIC gene. So if they are heterozygotes, they might sometimes have cholestasis. So you may have to correlate that if the mother's history suggested. Acute fatty liver of pregnancy is known to be associated with the heterozygote condition for 3-hydroxyacyl-CoA dehydrogenase deficiency. And maternal infections, as we always ask, for torch infections. In terms of the infant history, we have the gestational age, prematurity we discussed as well. Small for gestational age babies have a higher risk of syndromes and intrauterine infections. And we have other conditions which may contribute: alloimmune hemolysis, G6PD deficiency, hydroxyfetalis, which all contribute to increased risk of cholestasis, same as the hemolytic conditions, anemia we discussed. Neonatal infections, urinary tract infections, sepsis, and CMV, HIV, syphilis may also contribute. I told you that we should review the result of the newborn screen because we can pick up galactosemia, panhypopituitarism, fatty acid oxidation defects, and cystic fibrosis, also hypothyroidism. And the nutrition source, if it is breastfeeding babies, galactosemia has to be considered. Formula fed the same way, any lactose containing milk. And if there has been fruit juices introduced, you should consider hereditary fructose intolerance. I've seen one baby in a family, repeatedly the child used to worsen after 3 to 4 months when they started introducing sugarcane juice or other juices into the family. In that family, they were introducing early. And with this history, the child used to develop severe liver failure by 6 to 8 months and die. And this was the 4th sibling that we saw. Luckily, we were able to identify and manage that baby. And you have parental nutrition-associated liver disease. Of course, there are other conditions which you can review. Growth is associated with genetic, metabolic, hearing problems, PFIC can be having, or the tight junction protein mutation. Vomiting can suggest bowel obstruction, pyloric stenosis. The level of stooling and the color of the stool is important, and urine characteristics. Excessive bleeding may indicate coagulopathy and the associated vitamin K deficiency with liver failure. And irritability, lethargy is not typically seen in biliary atresia, but it may suggest metabolic disease or sepsis. If there is a history of previous abdominal surgery, NEC and TPN related can contribute, and also intestinal atresia may be associated with bile duct atresia, cholangiopathies. In terms of physical findings, the general health ill appearance may indicate infection or metabolic disease, and typically infants with biliary atresia are deceptively normal. So this is very important. Remember that the biliary atresia babies don't look unwell, so you may easily miss them unless you are really looking for the prolonged jaundice. So in terms of general appearance, we have dysmorphic features in Alagille syndrome. Remember that you may not pick that up in the newborn period. The typical dysmorphism, the broad nasal bridge, triangular face, deep set eyes, and sharp chin, they develop around 6 months of age. In terms of the vision examination and hearing assessment, you have congenital infection, septoptic dysplasia, and you can get posterior embryotoxon in the Alagille syndrome, and cataracts as well in intrauterine infections. Cardiac examination can be a feature of Alagille syndrome. You also get polysplenia and situs malformations in some specific types, syndromic types of biliary atresia. In terms of abdominal examination, you look for hepatosplenomegaly and abdominal masses, and umbilical hernia may suggest hypothyroidism, for example, or metabolic conditions. The stool examination is crucial, and it's better that you don't go by the parent's description. You try to look at the stool itself to see the color of the stool. We'll be looking at the stool chart as well next in the coming slides. And of course, in neurologic assessment, you look at the overall vigor and tone, because hypothyroid babies or babies with metabolic conditions can have altered tone.